Okay. Oh. Hmm. All right. Um, so we'll start with the nematodes today. So the nematodes, we have about nine of them or so. But just like we said yesterday, they are classified into two forms: the intestinal form and the tissue form. So the first one is the pinworm, which is Enterobius vermicularis. Enterobius vermicularis. That's the pinworm. So what is peculiar to the pinworm is just anaphoritis. So once you see the history painting anaphoritis, it's only one organism that can cause that majorly. Enterobius vermicularis, pinworm. It also all of them are okay, not all of them, but most of them are transmitted through the fecal oral route. So we are going to talk about the ones that are not predominantly transmitted through the fecal oral route. But you just have it at the back of your mind that almost all of them is fecal oral. Yeah. So the drug that used to treat almost all of them is the albendazole. So you can use albendazole, the bendazoles generally. There are so many of them. Mebendazole, albendazole, all those bendazoles. Yeah, you can use them to treat the nematodes. In addition to that, you can use parenteral palmate. So only two of these intestinal worms that you can use parenteral palmate in addition to the bendazole. And I feel the way you can master that is just by considering their other names. So one is pin, like there's a sharp end. The other one is hook. So anything that has sharp point, in its name, you want to use the parenteral palmate in addition to the albendazole. I don't really think they'll be testing this medication. Even if they test it, they will not want to test the other one. Just know that the worms generally, nematodes, the albendazole, the mebendazoles work for them. So in addition to the albendazole or the mebendazole, you can use parenteral palmate, and that parenteral palmate can be added to treatment for pinworm as well as hookworm and pinworm. Yeah. So we said the major presentation for Enterobius vermicularis or pinworm is the anal pruritus, which is very worse at night because that's the time that the female worm is going to come out to lay the eggs at the anal region. So that those eggs brings about the sensitization that triggers the inflammatory response, which is responsible for the pruritus. So you might also want to use a scotch tape to detect the presence of those eggs. So you put the cellophane tape at the anal region overnight. Then in the morning, you collect the tape, then you visualize it under the microscope. You are going to see the egg of this pinworm. So it has this pattern, but I don't think they expect us to actually memorize how those eggs look like. But this is the egg of Enterobius vermicularis. They will not show you the egg and ask you to make diagnosis. No, they are going to put a detailed history there to help us, make the diagnosis. Yeah. So the next one is Ascaris rhumbicoides. This one is very common. The other name is the giant roundworm. So not pinworm now. This is giant roundworm. Ascaris lumbicoides. It's also transmitted through the fecal oral route. So if somebody takes in um, food or water that is contaminated with the eggs, so the egg will travel down into the gastrointestinal tract, particularly the small intestine. So that's where they are going to germinate into the larva. So once it gets to the larva will, you know, puncture the intestinal mucosa. They will find their way to the blood vessel. From there, they will travel down into the venous system. They will return back to the heart. You know, when they get to the heart, they will find their way to the right side. To the pulmonary capillary. They escape through the pulmonary capillary into the pulmonary walls, the alveolar walls. So at that alveolar wall, they can trigger some inflammatory response. And you guys remember that the inflammatory response to worms. What immune component do you guys think will respond to parasite? So with your knowledge of immunity, which one do we think is going to respond to parasitic infestation?
Snuffles. Snuffles.
Yeah, like there's something that's going to bring about the attraction of those eosinophils. There's something that gets activated first before
Oh,
the
Jesus. Is that what you're trying to say? The antibody, the actors have been.
No,
semi-detached children.
no,
Uh,
not antibody, not antibody. There is going to be activation of the THEPA2 component. You guys
uh-huh.
remember that it is the
That
THEPA2?
that's what that will secrete the interleukin 5, right?
Exactly. So that's what's going to produce interleukin 4, 5, 6. So your interleukin 4 will help you release what? Your IgE. Your interleukin 5 will help you attract the eosinophils. So that all these things can work in concert to eradicate the worm. Yeah. So that is why you are seeing pulmonary hypoeosinophilia. We call that low flair syndrome. So there's going to be a response. That low flair syndrome is just like presentation similar to someone that has asthma. So they are going to be coughing, they are going to have dyspnea, they are going to be wheezing. So then if you check the blood film too, you are going to see eosinophilia. And if you do a chest x-ray at that point, you are going to see pulmonary infiltrate. In asthma, you don't expect to see pulmonary infiltrate, but someone that has low flash syndrome in response to parasitic infestation of the alveoli, there's going to be, you know, parasitic infiltrate on the X-ray in addition to the other symptoms of asthma as well as eosinophilia. So because the worms can get to the lungs, they can move out of the lungs. The lungs is just from the alveoli, it moves up to the bronchioles, from the bronchioles to the trachea, from the trachea, it moves up to the larynx, then the oropharynx. So from the oropharynx, they can go to the nose or they go to the mouth. So if you want to go to the nose, you ascend up to the nasopharynx, then they can pass to the nose. Once it get to the oropharynx, you just move anteriorly and they can, you know, get to the mouth. So you can have those worms coming out of the mouth or nose in people that are heavily infested. So now, if it gets to the oropharynx, it can be swallowed again. So once it attends to the trachea, it can get swallowed again down to the oropharynx, then it will go down into the gastrointestinal tract. But that form is already matured. So you have the adult worms already. So those adult ones can now cause obstruction. They can obstruct the intestinal mucosa and cause symptoms of intestinal obstruction. Some of them can find their way into the biliary tract and cause biliary obstruction. So you can even have jaundice because of biliary obstruction from worm infestation. So watch out for intestinal obstruction symptoms, especially when those worms aggregate together to form bulbs, and also biliary obstruction. So in some conditions, they can also perforate those intestinal mucosa and they can cause peritonitis. So that's just how the virus carries. Just always remember that once it gets into the intestinal mucosa, because at that stage they're actually in the larval form, so they can move out of the intestinal mucosa, get to the blood vessel, they find their way to the lungs. When they get to the lungs, they can trigger the low flow syndrome, and they are sent up the lungs to the oropharynx where they are swallowed back into the GI. By the time they get back to the GI, they are already in the adult form, so they are well developed, so they are big enough to cause intestinal obstruction, and also they can travel to the other part of the GI, including the biliary region, and cause biliary obstruction too, which can lead to eventual perforation of the bowel wall. So the one thing that is peculiar to them is just the appearance of the egg. So it's nobly coated, so it's very thick, like it has like different layers of coating. Can you guys see it? So this is how the egg looks like. Yeah, but you guys do need to master the way if you can recognize it, fine, but it's not something that will you know that you should really stress yourself on. So the treatment is the benzadole. So you can use the benzadole to treat it. So the next one is Strongyloides tecuralis. Strongyloides tecuralis is also known as threadworm. One thing that is peculiar to this one, two things actually, two things. Number one, you don't transmit Strongyloides tecuralis through fecal-oral route. No, it is one of those two worms that enters the body through penetration of the skin. Please, we have to remember that. Two worms enter the body through the skin. Strongyloides tecuralis or threadworm and the hookworm. So hookworm, two species or two genus rather, Acyclostoma as well as Necator. Acyclostoma and Necator americana, they are hookworms, alongside with Strongyloides tecuralis, which is a threadworm. Both of them through enter the body rather through the skin penetration. Very, very important, please. Very, very important. Another thing that you need to always remember about threadworm or Strongyloides temporalis is that it causes auto-infection. It causes hyperinfection. It causes hyperinfection. That is, it can keep reinfecting the body without even needing to get out and be going through the normal cycle. So what is the normal cycle? There's a form of the larva that we call the filariform larva. That filariform larva is what is going to penetrate the skin. Once it penetrates the skin, it finds its way into the lung. Once it gets to the lungs, it does exactly just like our ascaris will do too. They will ascend. Once they trigger the inflammatory response in the lung, they can cause hemoptysis, they can cause dry cough. Then they ascend the lungs to get to the oropharynx and they are swallowed back into the GI. So once it gets to the GI, it can trigger inflammatory response in the small intestine, particularly the duodenum and the jejunum. So it can cause duodenitis. So there's abdominal pain, there's nausea, there's vomiting, there can be diarrhea too from the duodenitis. Now, the filariform form, so by the time it gets to the GI, it's already as a matured worm too. So they will, because the matured worm, there are many. So you are going to have the female version, the male version. They are going to copulate, form the eggs. The eggs will transform into the rabitiform larvae. So that rabitiform larvae is the non-infectious form. The rabitiform larvae is the one that you see within the GI lumen. So the rabitiform larvae can now further develop into the filariform larvae. So once it gets to the filariform larvae, that one can be infective. So that one is the one that will now penetrate the intestinal wall and enter the vessel to go back to the lung again and start the whole process. So what is actually triggering all this manifestation is the filariform larvae. Now the concept of um, hyperinfection is that, okay, now once the adult worms get into the GI, the male and the female version, they mate, they give rise to the eggs. The eggs are passed out in stool. So you have the labitiform larvae developing from the eggs in the soil and they are transforming into the filariform larvae. Then you can now have that filariform larvae entering the skin again and starting the process. Instead of having that, some rabitiform larvae in the GI, they are not killed. So they can easily transform into the filariform larvae and the filariform larvae can now penetrate the intestinal wall and keep the cycle going. Why does that happen? If this individual is predisposed to any form of problem, any form, especially cellular mediated immunity, that cannot make it eradicate the worms, particularly the rabitiform larvae as well as the filariform larvae, and they are persisting in the body, they will keep auto-infecting that individual and cause hyperinfection syndrome. So that one is common in people that are immunosuppressed, people that are immunocompromised, especially when there's problem with the T harm, the T lymphocyte. What's the problem with the T lymphocyte? You cannot control these guys. So they just keep differentiating from the egg rabitiform larva to the filariform larva that will penetrate the intestine, start the process again. They don't even need to go out and be laying and be, developing from the soil and reinfecting. No, no. Although that one too can also happen in the hyperinfection. It's just that one is it will take time because you need the egg to, how do I put it now? To be in contact with the person, the egg will now develop into the rabitiform, filariform, then the filariform can now reinfect, even without needing to enter the soil. So the if this person now, let's say this person is getting having contact with the fecal matter containing the egg. So the fecal matter is in contact with the body, the filariform larva will develop from that egg, penetrate the skin and enter. That's another form of the auto-infection. But the best one that is actually the the better explanation for the hyperinfection is when the rabitiform larva within the body is not eradicated. So they can develop into the filariform larva, then can penetrate the intestinal wall, go to the lungs, get swallowed back into the GI, then it can keep reinfecting like that. So because of the fact that the first thing that they need to do before they can infect is to enter through the skin. So they will cause some cutaneous symptoms, particularly some, you know, itching around that area where they are entering. So you are going to notice itchiness around that area. When they enter, they go to the lungs. They trigger some pulmonary symptoms like dry cough and wheezes, chest pain. Then they get swallowed back into the GI as adult worm, causing duodenitis because they have preference for the small intestine. So don't forget the hyperinfection. The hyperinfection is very peculiar to Strongyloides stechuralis. Once you are seeing description of hyperinfection, you are thinking of Strongyloides stechuralis. So the larvae from the soil penetrate the skin. Then if you do this stool sample, the stool analysis, you are going to see the rabidiform larva. You might not see the filariform because that is the infective one that is penetrating into the intestine. But the one that will be in the stool will be the rabidiform larva. So you can use ivermectin or the bendazoles. So ivermectin, this is the only one that is using ivermectin here. Ivermectin. And you guys remember you can also use ivermectin for, okay, we've not mentioned it. I'm not sure we've mentioned it. Yeah. So we've not talked about it, but just know ivermectin and bendazoles for Strongyloides stechuralis. Strongyloides stechuralis, you want to remember hyperinfection, hyperinfection syndrome in individuals that are immunosuppressed that cannot control the population of the worms. So the next one is the hookworm. Two genus, Acyclostoma species as well as the Necator americanus. What is common to this hookworm? What do you watch out for? Iron deficiency anemia. Once you are seeing the blood picture, MCV less than 80, you are seeing a microcytic hypochromic cell on blood smear, you already know that this is iron deficiency anemia from parasitic infection. What parasite? What parasite? Iron deficiency anemia. You are thinking of your hookworm. You are thinking of your hookworm. Now, because hookworm, just like Strongyloides stechuralis, enters through the skin. Once this guy enters the skin, he doesn't know where to go to immediately. So they wander through the skin initially and they cause what we call cutaneous larva migrans. The filariform larva of this hookworm, they also enter through the skin. So someone that is walking barefooted and the person can, get exposed to that larva from the soil. The larva penetrates the skin and wanders within the skin for some time before it finds its way into the lung. So that wandering is going to cause some inflammatory response that is very pruritic, and we are going to see snake-like rash that we call serpiginous rash. I think we have it here. So this is what it's going to look like. Can you guys see it?
Yeah.
So this is serpiginous rash, from the hookworm infestation. So once you see this, you are thinking of cutaneous larva migrans. There's another organism that causes visceral larva migrans. So that one just wanders within all the organs of the body, the brain, the liver, the spleen, the lungs. Yeah, and it will cause inflammation of all those areas that it is wandering about. That is Toxocara. We are going to talk about it. So you have to remember the two. Cutaneous larva migrans is for hookworm. Visceral larva migrant is for Toxocara canis disease. Yeah. So don't forget, although strongyloides also enters the skin, but it doesn't cause the cutaneous larva migrant. It goes directly to the lung. But once you are seeing cutaneous larva migrants, you remember the hookworm, and you are seeing iron deficiency because what they do is that once they get back to the GI, they start sucking the blood. They start sucking the blood from the intestinal wall. They attach to the wall of the intestine through their hooks and they keep sucking. That's why they call them hookworm. They keep sucking the blood and you know they can cause iron deficiency from there. So
Suck the body dry.
yeah, they suck the blood dry. Yeah. So just like pinworm, we said the both of them have some hooks, some pin at their end. So you can use the bendazole as well as the parental palmate to treat it. Another one is Trichinella spiralis. So Trichinella spiralis is one of those ones that you can acquire through fecal oral, although it's not very common. So the most common way of transmission of the Trichinella spiralis worm is actually by eating uncooked meat, particularly pork. Why? Because we cannot be talking about the whole life cycle, but the major thing to just remember is that the larval form of this Trichinella spiralis ensists within the muzzle of the pork. So the pigs are going to consume the egg. The eggs are going to transform into the larva. The larva is going to travel around the muscles, the blood, wanders around, get to the some tissues, particularly the muzzle, and it will insist there. Now, humans that consume pork that is not well cooked, that they've not killed off those encysted lava, they'll take in that lava into the GI. So once it gets to the GI, it's going to cause some problems. So it can just most of the time it's asymptomatic, but in some cases it can just trigger some mild vomiting and diarrhea. The lava migrates from the GI, penetrates the lumen, the wall, and enters the blood vessel. Once it gets to the blood vessels and enter the systemic circulation, there are some classic systemic inflammatory response that is going to respond to those Trichinella spiralis lava. And the characteristic finding is number one, you must not forget periorbital edema, guys. Very high yield. You cannot talk about Trichinella spiralis or trichinosis. Trichinosis. You cannot talk about trichinosis or trichinosis rather. Trichinosis, and you don't mention periorbital edema. That is not complete. Trichinosis is characterized by periorbital edema, which is a form of vasculitis that happens in response to the presence of those worms in the blood. So it's going to trigger vasculitis within the face that will bring about periorbital edema. These worms are going to travel around the body because they have predilection for staying within the muscles. They go to the muscle, they trigger inflammatory response in the muscle when they insist. So they are going to insist in the muscle and they cause myositis. So that muscle inflammation is going to bring about muscle pain, causing myalgia. So once you are seeing history of myalgia, muscle problem, alongside with periorbital edema, it is only trichinosis that can explain that. Don't forget. Although it can go to other places, it can go to the brain, but most commonly it stays within the muscle. That's when it's going to insist. So once somebody consumes meat that is contaminated or infected with the cyst of trichinella, once the food items get into the GI, they are going to exist. So that cyst is going to exist from the meat or from the muscle, and is going to infect the intestinal wall, find its way into the blood vessel, travel around, trigger some systemic inflammatory response that is going to cause vasculitis, particularly in the face, causing the periorbital edema that they have. Then it's going to also travel to where you have abundant muscle and cause myositis, leading to myalgia. So, most common way of getting it is not by eating food or water that's containing the eggs, but by eating uncooked meat, particularly that of pigs that contains the cyst. You treat it with the bendazole too. So the last one for the intestinal nematode is Trichuris trichuria. Once you hear Trichuris trichuria, that's whipworm. What comes to your mind is rectal prolapse. That is it. It's very easy. That's the only way they can nail Trichuris trichuria. That's when it can be clinically relevant, when it causes rectal prolapse and there's passage of loose stool. Now, what happens is that this whipworm, once it's taken in, through the fecal route, it has preference for affectation of the colon. So it particularly goes to the rectum and causes rectal inflammation, proctitis. So from there, it's going to worsen and it will eventually lead to rectal prolapse. So there can be bloody stool sometimes, you know. So, but they typically have diarrhea, you know. Sometimes when it's bloody, it can lead to anemia and it can have, the typical rectal prolapse. So we are just looking for rectal prolapse. Once you see rectal prolapse from inflammation of the rectum leading to eventual prolapse of the rectum, you are thinking of whipworm. It's only whipworm that can cause that. Out of this worm, that is a distinguishing feature. So Trichuris trichuria, you are watching out for rectal prolapse. Trichinella spiralis, you are watching out for periorbital edema and myalgia from pig. The hookworm, which includes acyclostoma as well as Necator americanus, you are watching out for iron deficiency and also your cutaneous liver migrant. Strongylosis temporalis, that's hyperinfection. Hyperinfection. It can also enter through the skin, but it's hyperinfection that is, one of those clinicals. And you also see the triad of um, affected skin lesion, pulmonary symptoms, as well as GI. You guys know that cycle. We've said it so many times. Enter through the skin, pruritic rash, or pruritus generally. You won't see the serpiginous rash because that's the cutaneous liver migrant. So it's just going to cause pruritus at that side of entry. It's going to the lungs, causes the hemoptysis and the dry cough, gets back into the GI, cause the rhinitis. Then ascaris is more of intestinal obstruction, biliary obstruction, eventual intestinal perforation. It can also trigger the low flow phenomenon due to affectation of the lungs too. Enterobius vermicularis is P1. This one is anal pruritus, and you detect it through the Scotch tape. So that is that. So this is a muscle containing the encysted form of the larva. So these are the larvae within the muscle. Yeah. So so um so let's go to the tissue nematodes. Four of them. Toxocara canis is the one that causes the visceral liver migrans I'll try to explain. So it's acquired through the fecal route, particularly if somebody takes in food that is contaminated with the eggs, particularly um, food that is contaminated with dog feces. So because this Toxocara can is one of the hosts, you know, are dogs. So dogs are one of the hosts for Toxocara canis. So the eggs are shed alongside with the fecal matter of the dogs. If they find their way into the water bodies or the food, and it's being consumed by humans, they can get to the GI and start causing problems. So once they get to the GI, they mature as the adult worm. They penetrate into the blood vessels and they start moving around all the organs one by one. So we usually have the cutaneous form and the visceral form. I said cutaneous, ocular form, and the visceral form. So it can go to the eyes and cause retinal fibrosis, which can lead to visual impairment. So that's the ocular form of the liver migrant. The visceral one is now when it starts going to the other solid organs like the CNS, causing encystment within the CNS, so to cause like some inflammatory response in the CNS that's going to cause it can stay there. It can stay there, colonize the region and cause seizures, coma. It can go to the heart, trigger inflammatory reaction in the heart, leading to myocarditis. It can affect the liver, so leading to hepatitis, which can be detected as hepatomegaly. So you want to watch out for the heart, the CNS, and the liver. So there's going to be enlargement of the liver. Visceral liver migraine is one of the causes of liver enlargement because of inflammation of the liver from the passage of the worm. So the worm just moves through all this region, and once it moves through them, it's going to trigger inflammation as it's passing through them. So the inflammation can even end up as fibrosis at the end of the day. So it gets to the eye, inflammation in the eye, retinitis, which fibros, leading to visual impairment, can get to the liver, hepatitis, inflammation of the liver, leading to hepatomegaly, can get to the heart, causing myocarditis. It can also trigger inflammatory response in the CNS, leading to like a form of encephalitis, which brings about seizures and coma. Sometimes they can also be asymptomatic. So don't forget visceral liver migrants, almost all the solid organs, particularly the heart, the brain, and the liver. It can also affect the eyes too. So once you are seeing eye involvement, you don't want to think, maybe you don't want to jump into like maybe river blindness. You want to calm down and look at the other findings to be able to nail the appropriate diagnosis. So that's that about the Toxocara canis, because this one don't typically affect the GI. So that's why it's not classified as intestinal um, nematode, despite the fact that it's transmitted to the fecal route. It doesn't typically cause very serious GI infection. Typically affect the heart, the CNS, as well as the liver, then the eyes too. So the next tissue nematode, is Onchocerca volvulus. So Onchocerca volvulus, I know we are very familiar with this. So Onchocerca volvulus. One thing about this Onchocerca volvulus is that it's transmitted by the female black fly. So the Simulium fly, the female black fly, you tend to see these flies colonizing water bodies. So where you have rivers, that's where they stay. So they contain the microfilariae of this Onchocerca volvulus. So once they bite somebody, they can introduce that microfilaria into the skin. Then it can find its way into the blood. But before it leaves that skin, it's going to cause some irritation of the skin, some symptoms within the skin. So there are a lot of them. There are a lot of them. But what I just want you guys to always remember that it can cause both hyperpigmentation or hypopigmentation of the skin. So depending on the duration, it can cause acute dermatitis, it can cause chronic papular dermatitis. They will destroy the elastic fibers of the skin and make the skin not elastic again. They affect so many parts of the body. They can affect the upper limbs, they can affect the lower limbs, and cause those skin problems. So we just noticed. I don't know if you guys have heard of hanging groin before. Have you guys heard of hanging groin before? Hanging groin.
Yeah.
Yeah. So this onchocerca volvulus can cause that. Why? Because it can affect the skin within the lower limbs, particularly those of the groin, and they will lose their elasticity. So they will atrophy. They'll be very weak. They'll just be folding on each other because they won't be tense. The tensile strength is already lost. They'll keep folding on each other. So that's what we call the hanging groin. They can cause atrophy of the skin because they destroy the elastic fibers. They can cause some inflammatory response that is going to bring about hyperpigmentation or hypopigmentation. So when it's chronic, they usually cause the hypopigmentation. So you just see some dots, some patchy hypopigmentation in the skin, which we call the leopard skin. Leopard skin, you know. And acutely, they can also colonize the skin and cause subcutaneous nodules. So they can go to the subcutaneous tissue. The adult worms are going to colonize that area and they will form skin nodules. So in addition to causing dermatitis, they can form subcutaneous nodules within the skin. So you have um, skin nodules, you have the dermatitis, which can come in form of hyperpigmentation or hypopigmentation. If you are seeing the hypopigmentation, you know that that is a chronic thing, which is the leopard skin. It can cause atrophy of the skin too. Atrophy of the skin. Then they can go to the eyes. So they have predilection for traveling to the eyes too. Once they get to the eyes, they can affect from the outer layer to the innermost layer. So they can cause keratitis when there's affectation of the cornea. They can cause scleritis when there's affectation of the sclera. They can cause choroiditis, iridochoroiditis when there's affectation of the middle layer, the iris, the choroid. They can now affect the retina too at the back, which will lead to river blindness at the end of the day. So there's going to be blindness. We call river blindness because you get the flies from the river, and when it eventually brings about loss of vision, we call them together, and it's known as river blindness. So you are looking for the skin manifestation and the eye manifestation with respect to Onchocerca volvulus. The skin and the eye. The skin and the eye. The skin and the eye. So they used to talk about one allergic response, but they have removed it. I'm happy they have removed it. That is actually the Mazotti reaction. I know you guys have heard of that now. Have you guys heard of Mazotti reaction?
Can't remember.
But you've heard of it, Shay.
Yeah, I think
No,
so. I can't remember.
Dr. Toby, you have not heard of it.
never.
Okay, there's Mazotti reaction. It's like a reaction that happens when you are giving dietary carbamazine to treat Onchocerca volvulus. So maybe they are thinking it's infection from lower or the other one, like whichever bankruptcy. They're now giving diethyl carbamazine. It can trigger the Mazotti reaction. So there's going to be like fever, tachycardia, hypotension, skin rash and all those things. You know, they have removed it. So it's okay. It's okay. It's not high you, that's the meaning. So the next one, tissue nematode, lower. So lower, one thing about lower is that they will tell you in the history that you are seeing worms moving through the eyes. So once you see that, you are thinking of lowasis. Now, one thing about this guy is that it doesn't cause blindness. Once you are seeing blindness and you are thinking of a worm, it is Onchocerca volvulus. Lowasis can have the worms traveling through the eyes, but they do not cause blindness. So the major characteristic symptoms for lowasis is that number one, they cause swelling in the skin, they cause swelling in the joint. That is all. So there's what we call Calabar swelling. Calabar swelling. I don't know how they come about the Calabar. Maybe the worm is common maybe the flies are very common in Calabar area. I don't know. But they call it Calabar swelling. So what is that swelling? They will cause swelling in the skin. So once the deer fly, the horse fly, or the mango fly, they are all called the chrysops fly. Once they take a bite, they can inoculate the microfilaria of the loasis into the skin. So once they get to the skin, they will trigger some inflammatory response in the skin, which will lead to swelling and pain. They can travel to the joint, they will cause joint swelling and pain too. They can now find their way to the eye. So you just notice episodic movement of the worms through across the conjunctiva of the eye. You guys know that the conjunctiva of the eye is transparent. So you can see the worms that is moving across the conjunctiva, moving down, moving up, but not causing visual problems. It doesn't cause blindness. That is Loasis for you. And what transmits it? The cresol fly, which includes the deer fly, the horse fly, or the mango fly. Any one of these guys, they can cause Loasis. What is the treatment? Dihethylcarbamazine. Don't forget the treatment for onchocerciasis, ivermectin. It goes standard. That is it. You can't miss it. Maybe okay, they are giving us clue. River blindness, like ivermectin. Yeah, so I think that works. And don't forget, you can also use that for ivermectin to treat this guy, strongyloides tecorosis.
Congratulations.
Yeah, nice one, Dr. Toby. So Loasis, don't forget, skin and joint, and it's only swelling. So swelling and pain in those areas. Then it will go to the eye and be migrating to the eye. That's it. Just passes through the conjunctiva. That's Loasis for you. That's Loasis. Dihethylcarbamazine. Wuchereria bancrofti and Brugia malai, Brugia timori. Those ones are lymphatic worms. So what they do is that once the mosquito can transmit it. So all the mosquito, Aedes, Culex, Mansoni, Anopheles, they can contain this filaria, the microfilaria of this Wuchereria bancrofti and the Brugia malari. They inoculate them into the lymphatics. So once they get to the lymphatics, they proliferate in the lymphatics. That's where they proliferate, and they cause lymphatic obstruction. So when they invade the lymph node, they cause lymphadenopathy, they occlude the lymphatic lumen, they cannot drain lymph again. So you are going to have accumulation of lymphs within the body, which will lead to lymphedema. So you are just going to notice abnormal thickening of that skin. If you touch this skin now, it's going to be abnormally thick because of that excessive accumulation of the lymph in that area. So you are going to have swelling of any part. It can happen in the leg, it can happen in the arms, it can happen in the breast, anywhere. You just have lymphedema of that area. And it takes a while because it's going to be a chronic inflammatory process. So the ventral fibrosis of the lymphatic is what is causing the edema, lymphedema, and it can take as much as 9 months to a year before it eventually starts seeing the symptoms. So what they have reduction for is just the lymph node. They go to the lymph nodes, they occupy the lymphatic vessels, block them, and you cannot drain lymph. So once you are seeing elephantiasis, the legs, the body part, they are big, like that of a elephant. You are dealing with the lymphatic worms, the lymphatic nematodes, which include Wuchereria bancrofti or Brugia malari. And what you use to treat them is the dihethylcarbamazine.
Dr. Bali,
Yes, Dr. Abisola.
does the lymphedema, does it resolve with
Which one? The what?
the elephantiasis? Does it resolve?
I'm not sure, but I think it should resolve. I think so. I'm not sure.
Okay, now.
I'm not sure. Yeah. So that is that about the worms. So let's talk about the cystodes, the tapeworms, the tapeworms. So there are about three of them: Tinea solium, Diphallopotrum latum, and Echinococcus granulosum. They are very easy to identify. There's no way they will paint that history that will not get it. Tinea solium is just two things that brings it into the spotlight. It causes intestinal problem and it can cause CNS problem. So that is it. So if somebody, there are two ways by which somebody they can acquire this tinea solium. So if somebody takes in the eggs, so you call that cysticercosis. So it's the egg that the person is taking in that is now eventually developing into the worm into the person. That is cysticercosis. But in some people, they can take in the larva. So that larva can exist within the pork. It's just like Trichinella spiralis. Tinea solium, can also have its larva encysted within the pork, the muscles of the pork. So if somebody takes in that larva directly, they just go to the intestinal wall and they start causing symptoms of tiniasis. Most of the time it is asymptomatic. They don't cause anything. Tiniasis is problematic when it finds its way to the brain and cause neurocysticercosis. That's when it's bad. That's when it's a very bad boy. But if it's within the intestine, it's not very severe. But even if it wants to cause anything, it can go beyond abdominal pain um what's it called, feeling of bloating sensation, um indigestion. So those are the typical things that you just see when there's the intestinal tapeworm. I'm just mentioning that one so that you can know that it can cause, you can have intestinal tenacious. That's it. And you just give praziquantel. So praziquantel is actually the one of the treatment of choice with peculiarity to the cystoid. So if you want to treat the tapeworm, one of those things that you can use is praziquantel. Praziquantel for the tapeworms. Don't forget. So the dangerous pathology from the tinea solium is when it causes neurocysticercosis. So somebody can take in the eggs, they proliferate, they develop the lava moves into the blood, then travel to the brain. They can cause multiple cysts in the brain. So neurocysticercosis is one of the differentials for multiple Ring-Enhancing lesions. So, but you just see tiny calcification, tiny like cyst-like stuff. You guys can see these tiny things. When you are seeing these tiny things like this, my sister, you are thinking of neurocysticercosis. Tiny lesions, in the brain, which are actually the cyst of, you know, why. So they are forming the cyst. They go to that area. The adult worms, they lay their eggs and they encyst within that area. So that's it. So the larva will encyst itself within that area, and you can have neurocysticercosis. So they can present with all manner of neurologic manifestation, anything you can think of. Seizures, you know, paralysis, difficulty talking, confusion, personality change, anything you can think of, anything. But the clincher is just that you are seeing cyst-like lesion, you know, in multiple areas of the brain. Ah, that's likely to be neurocysticercosis. It's very bad. It's very, very life-threatening. So, um, how do you want to treat it? You just give praziquantel, and you have to add albendazole to that for the neurocysticercosis. So, you add albendazole when the person has a neurologic problem. You have to add albendazole. Yeah, don't forget that. Don't forget that. Albendazole, very important to treat the neurocysticercosis. In addition to praziquantel to eliminate the worms within the blood, you can also need to give albendazole to take care of that one that have penetrated into the brain. Another one is the Diphyllobothrium latum. So Diphyllobothrium latum, this fish tapeworm. So you don't get this from pork. You don't get this from pork, but you get it from fish rather, from fish, freshwater fish. So the freshwater fish contain the larvae. So if you take this freshwater fish that is not properly cooked, you can have the larvae introduced into the body. They can travel to the GI, and they will just settle down with the gastrointestinal tract and be sucking all the vitamin B12 that is there. So that's what they do. They cause vitamin B12 deficiency. They compete, you know, for the red blood cells, the white blood cells, and other thing for vitamin B12, and it's going to cause megaloblastic anemia at the end of the day. So don't forget that. That Diphyllobothrium latum, what you are just watching out for is vitamin B12 deficiency. So they can just put some clinchers that will make you make diagnosis of vitamin B12, maybe MCV greater than 100, and they will tell you the um, hypersegmented neutrophils, macrocytes in the blood, ovalocytes, all those things, just to make you think about vitamin B12 deficiency. And they will now ask you which of the following options can explain this laboratory finding. You are just looking for, you don't need to be a genius to know this is Diphyllobothrium latum. So, and that person will now be looking for pernicious anemia, they'll be looking for all those things. But Diphyllobothrium latum is also one of those organisms that can cause vitamin B12 deficiency. So, we must always remember that. We should not forget. Iron deficiency anemia, it can either be, is mostly hookworm, but there are some worms that can also cause it. For example, the schistosoma. But have it always at the back of your mind. Number one, hookworm for iron deficiency. Vitamin B12 deficiency, Diphyllobothrium latum, which is fish tapeworm. The tapeworm that you get from consumption of uncooked freshwater fish. So just like other cystoid, you treat it with the praziquantel, then you can add nucleosamide. Nucleosamide can also be used to treat tinea solium too. So yeah, so when you are seeing praziquantel, nucleosamide, you know that this is actually a cystoid, a tapeworm problem, a tapeworm problem. So they can ask this guy. They ask it a lot. Please don't forget it. Yeah. So the third one, Echinococcus granulosus. Echinococcus granulosus is one of those guys that can cause abscess in the body, particularly in the liver, just like Entamoeba histolytica. That's what it's known for. So they form what we call hydatid cyst. So they can form cysts within the liver that will look like abscess. Now, that cyst has this eggshell calcification pattern. So this is the way it looks like. Now, this image is the larva of the Diphallobrotum latum. This is the larva, yeah. So D is the eggshell classification, for this Echinococcus granulosus. So Echinococcus granulosus is being acquired when somebody ingests the egg, from food that is contaminated with the dog feces. So the sheep are the intermediate host. Intermediate hosts are just like hosts that the asexual form of that organism passes through. The female and the male do not reproduce within the sheep. They reproduce within the definitive host, which is the dog. So once the dogs are exposed to meat from sheep, dog eat meat, so they can take in the Echinococcus granulosus larva from the meat of the sheep, and you can have development of the larva into the adult form within the dogs. So they complete the sexual cycle, they mate within the dog, they produce the eggs can now be released in the feces of the dog. So from there, the dog feces can contaminate food, and an individual can take that in, and the person will have the Echinococcus granulosus. So they can travel. The eggs can travel anywhere and exist anywhere. So, but predominantly they settle in the liver and the lungs. So when it settles in the liver, on the ultrasound you can see something that looks like eggshell calcification. So yeah, and you can make your diagnosis of echinococcus. So most commonly they will tell us the description of that mass. If they want us to think about the echinococcus, they will mention this eggshell calcification as one of those classic finding for echinococcus. Then one thing that they commonly test about it is that the concept of the anaphylaxis that it triggers. So those cysts are very, very unstable. They can rupture easily, and once they rupture, they can release the antigenic component to the blood that can trigger anaphylactic response, which is very severe. When it happens, I think the mortality is like maybe like 70 to 80%. Most of them will die following the rupturing of those cysts. So that's one thing you always want to pay attention to. Once you see in the history, they are saying the person just going through the anaphylactic shock suddenly, and the person has a liver mass, an abdominal mass, you are thinking of Echinococcus granulosus. You are thinking of that. So the treatment option is albendazole. That's what you give. You give albendazole. It can help with the resolution of the cyst, particularly when the cyst is not very large. So you might need to do surgery for large cysts, particularly cysts more than 15 cm, or complicated cysts. So there are so many descriptions for complicated cysts. We are going to see many septa in complicated cysts. We are going to see um, two different tissue types. So you see solid mass, you see liquid mass, or should I say liquid mass now, or cystic mass. So once you are seeing something that looks like fluid, and you are seeing something that is alternating with solid mass, so you know that this is likely to be a complex. A simple cyst is uniform, is homogeneous. Is that it contains solid component or fluid component. It doesn't have the mix. But once you are seeing the mix, both like here now we are having both solid and liquid. So this cystic one is this brown one, and we can see this black one, the solid mass. So we know that this is like more like a complex, cyst. And they will tell you too that they have septation. That's another thing, and it's not homogeneous. It's not homogeneous. The border is not well defined. All those things, those are the things you look out for to differentiate between a simple cyst and a complex cyst. So once it's complex or complicated, you must do surgery because it has a high chance of rupturing. You must do surgery. Yeah, so that's that about Echinococcus granulosus. So one of the differential for that is also Amoeba histolytica causing, liver abscess. Yeah, but in addition to all these things, you are going to see diarrhea, which will be bloody. So once you see bloody diarrhea with someone that has a liver abscess, you know that is like, or a liver present like a similar presentation like what we are seeing here, and this person is having diarrhea that is bloody, you know that is entamoeba histolytica. But most of the way they ask this question on this echinococcus that they will tell you this liver finding, and they can just say that the person suddenly develops hypotension, tachycardia, bronchospasm, difficulty in breathing, and all those things. You know that the person has gone through anaphylactic shock following rupturing of the cyst of the echinococcus. So you can find the cyst in the lungs. You can also find it in the liver. So those are the two common areas where you find the cyst. Yeah. So don't forget albendazole. So this one doesn't follow the typical pattern of praziquantel. You give albendazole to take care of the cyst, especially in uncomplicated situation. But once it becomes complicated, you must do surgery immediately. ASAP. Yeah. So let's talk about the trematodes. The uh the trematodes, um they are about three. No, is it three or four? Yeah, four. Actually, they are majorly two: schistoma as well as chronic sinensis. So those are the ones they want us to talk about: schistoma and chronic sinensis. Schistoma have three species. So we have the schistoma hematobium, japonicum, and mansoni. So I'm happy that they did not talk about the names of the vector. So we don't need to memorize the name of the vectors. We should just know that it's being transmitted by the snails. So, the snails are the intermediate host for the schistoma organisms. They are the intermediate host. So the snails contain the cercariae. Those cercariae are going to emerge from the snails and enter the fresh water. They can stay there for like 2 days. So once somebody enters those fresh water and swims, they can take in the cercariae. The cercariae will penetrate the skin and it will enter the person's body. Now, depending on the organism, depending on the species, that will determine the eventual destination of that cercariae. Now, if it's Mansoni or Japonicum, those ones cause intestinal schistosomiasis. If it's Schistosoma hematobium, like I don't know how to link that one to bladder, but maybe the B, maybe the B, but hematobium is bladder. Bladder. That's where it goes to. It goes to the vesical venous plexuses. That's where it enters. Once they enter the skin, they go to the blood vessels. Then they find their respective venous plexuses. So Mansoni will go to the inferior mesenteric venous plexus, or vein rather. Japonicum will go to the superior mesenteric vein. Hematobium will go to the bladder venous plexus. So it means that both of them, some of them are going to the bladder, some of them are going to the intestine, particularly the large intestine and the small intestine. So, and they'll start causing the problems there. What is peculiar to these guys is that whenever they find themselves, it is the eggs that they are laying there that causes the problem. That is it. It is not the presence of that organism itself. It is the eggs. Those eggs are highly antigenic. So once they get to the plexuses, they start laying those eggs. They start laying those eggs. So they can cause intestinal irritation in response to those egg laying, which can bring about. Sorry about that, guys. So once they enter the supramesenteric vein, the inferior mesenteric vein, they can move out, go to the intestine, and they start laying their eggs. So which can bring about intestinal irritation, which causes the diarrhea, the abdominal pain, and all those things that they experience. Yeah. They can also cause, inflammatory response. Okay, you said that. Yeah, so it can find its way from the mesenteric venous plexus, or the inferior mesenteric or the superior mesenteric vein, to the hepatic vein, hepatic portal vein. You guys know that hepatic portal vein is formed by both the superior mesenteric vein and the splenic vein. So from the superior mesenteric vein, they can travel into the portal vein. Once they get to the portal vein, they start causing fibrosis in the liver. So they cause fibrosis of the sinusoid of the liver. There's inflammation leading to eventual fibrosis of the sinusoid of the liver, which will eventually cause portal hypertension. So that is why the gastrointestinal one are the ones that are most um, predisposed to causing the portal hypertension. So once you are seeing somebody having portal hypertension from a parasitic infestation, you know that it's likely to be an infection from the gastrointestinal wall, the intestinal schistosomiasis, which is caused by Schistosoma mansoni, and Schistosoma japonicum. Those guys. So the person start having ascites, start having the hematemesis, start having caput medusae and all those things. Yeah. So once they are saying that, you know that this is likely to be schistosoma. And you guys remember that it can also cause what condition in the lung? Let me see if you guys can remember. What condition can there?
That's why I actually opened my mic. I wanted to ask that the lung disease, like what exactly does it cause in the lungs?
Yeah. So what does
Pulmonary
it cause?
hypertension.
What did it cause? What does it? Why did you? Is it that you remember that it causes some lung problem?
You said like one of its causes goes to the lungs. So I'm now about to ask that what does it cause in the lung? That's
Yeah,
why I can.
we have done it too. So you guys cannot remember. Dr. Abisala, do you remember?
Yeah, we've done it.
Dr.
The lung
Olatobi? Hmm?
hemoptysis.
Emote Dr. Abisala. Well, well, maybe it can cause hemoptysis later.
Hypertension.
Yes, pulmonary hypertension. Pulmonary hypertension. Why? Because you can have embolization of those eggs to the pulmonary vasculature. So once they get to that pulmonary vasculature, there's going to be inflammatory response, there's going to be fibrosis, which will eventually lead to pulmonary hypertension. So that's why pulmonary
Is
hypertension,
it both the Mansoni and Japanicum, or which one exactly?
it can actually be any one of them, but it's more common
Okay.
for the hematobium. It's more common for the hematobium.
Okay.
Yeah. So, you know, that's that. So don't forget that they can cause pulmonary hypertension. They can cause pulmonary hypertension from the entry of the eggs into the pulmonary vasculature. So once they embolize to that area, it can cause fibrosis and hypertension. Yeah, so the intestinal attachment can also bring about the iron deficiency anemia. So they just suck the blood too, and they can lead to iron deficiency anemia. But the major clincher that you are looking for with respect to this schistosoma is the portal hypertension. That's what they will commonly ask. Portal hypertension. Once you are seeing that, an infection, schistosoma, and you are not going to pick hematobium because hematobium is confined to the bladder. So once it enters to the venous sinus, it can enter into the bladder. Once they get to the bladder, they start laying their egg in the bladder. And we've said that the next thing is inflammatory response. So the inflammatory response in concert with the irritation from the egg will lead to squamous metaplasia of the transitional epithelium of the bladder. So it's going to undergo squamous metaplasia that can now differentiate into a squamous cell carcinoma. So that is why schistosoma hematobium can cause squamous cell carcinoma of the bladder. What other thing can cause squamous cell carcinoma of the bladder? Anybody?
Infection.
Infection. Which infection?
Cyclophosphamide.
Are you talking about
Which infection
PSAC?
are you thinking of?
Acrolein. Cyclophosphamide.
Cyclophosphamide. Okay,
Phenacetin,
but
smoking.
those ones are more of
Chemotherapy.
hemorrhagic cystitis. So once they are seeing hemorrhage, inflammation with peeing of blood, that's what they usually cause. It might not, well, it might get to cancer, sure, but the dyes, yeah, you can talk about.
Benzene.
Can talk about the dyes, yeah, yeah. Can talk about the naphthalene dyes, aniline, all those things. So people working in textile industry, they don't forget the number one. You guys not mention. See, we've said it.
Smoking.
Yes. See,
It's
I don't want to
PSAC,
know. I don't
smoking.
want to know. I don't want to know that condition. Once you hear squamous cell, you must number one mention smoking. You can never. Most of the situation will be correct. Smoking. Eh?
Is it a that are you actually that was my question.
You
Yeah,
said
I realized that's what are you asking for infectious causes or generally all causes
no. I'm
of
just asking for general. We've talked about the infectious cause. I've talked about
That
the hematobium. That's why I'm now asking. Okay, what other things? So that's why I'm asking. Yeah. So I'm just trying to refresh your memory about the squamous cell. So yeah. So smoking is the number one for bladder cancer. Known as having a very large packet. They are joking with bladder cell carcinoma. I said bladder. Squamous cell carcinoma of the bladder. And what other cancer? Anybody? Smokers. There's another cancer apart from lung cancer that you want to always consider. People that are smoking in the urinary tract. Which other one?
renal
Renal.
cell.
Renal cell
I've
carcinoma.
already said that yeah. So renal cell carcinoma. So smoking is a very, very so yeah. So let me mute. I think I okay. So the hematobium, they cause irritation, which leads to the squamous cell carcinoma at the end of the day. But before it eventually gets to the cancer, they can cause hematuria. With the cancer, but before the cancer too, when there is the cystitis, the inflammation, they can cause hematuria that is painless and it is terminal hematuria. So once you are seeing total hematuria, you are thinking of a problem that is that is coming from up, maybe from the renal, or from the urethra. Where there is like renal trauma or who has renal cell carcinoma, they usually have a total hematuria because it is from the start of the urine that you are going to be having the blood. But for bladder, it's usually terminal because they will have settled. So it is the one that is now coming last that will now take out, the settled blood. That is that about um, bladder cancer. So once you are seeing terminal hematuria, you are seeing exposure to maybe any of these ones or smokers or anything, that's likely to be squamous cell carcinoma of the bladder. And we have explained why they can cause pulmonary hypertension, where there's embolization of the eggs into the pulmonary circulation. Yeah, we should not forget that. Cronarchy sinensis is also one of those worms, that somebody can get, and it's one of the trematodes. So this one is not mediated by the snail transmission. No, it is actually due to consumption of the undercooked fish. So just like our Diphyllobothrum latum, this one too is fish, not snail. Oh guys, don't go and pick snail. It is fish. So this fish contain the microsecariae. So once they take in, or the metasecariae rather, once they consume the fish, the metasecariae moves out, enters into the gastrointestinal tract. It has predilection for the biliary tract. It goes to the biliary tract, causes biliary inflammation, obstruct it, accumulation of bile. It actually thrives on bile. That is one thing about Cronarchy sinensis. It feeds on bile. So it wants to go to wherever bile is. So it stays within the bile duct that can accommodate it. Feeds on the bile there. They proliferate, they obstruct the bile. There's superimposed bacterial infection, which can eventually cause cholangitis. So now you won't have cholangitis for me. The superimposed bacterial infection can cause pigmented stone. You guys remember the cause of pigment stone now?
Yes.
Hemolysis.
Yes,
Hemolysis.
infection.
Hemolysis. Thank you, Dr. Oluwatobi. Infection. Yes. Infection. Yeah. So, those are total parenteral nutrition. There are a lot of them. So what's it called? The final common pathway to just explain pigmented stone is that there is an unconjugated hyperbilirubinemia. That is it. So how does it happen? Is that you are producing too much unconjugated bilirubin, or you are converting the conjugated bilirubin to unconjugated form through the activity of the beta-glucuronidase. So there's this beta-glucuronidase that is elaborated by the bacteria that colonizes the biliary tract. So they can convert the conjugated one to unconjugated. The unconjugated one can easily undergo enterohepatic recirculation to go back to the liver. Then with the way they are coming, they are coming, they can precipitate and cause the pigmented gallstones. So too much enterohepatic recirculation from deconjugation of conjugated bilirubin can cause pigmented gallstone. So the chronic uveitis can cause that because it will eventually lead to biliary tract inflammation, biliary tract obstruction, superimposed bacteria with eventual biliary tract epithelial hyperplasia. So that hyperplasia is a nidus. It's like a scaffold for the eventual development of the cancer. So you cannot have progression to cholangiocarcinoma. Cholangiocarcinoma is cancer of the gallbladder. I've been now, guys.
Yes.
Yeah.
There's a catch there. Cholangiocarcinoma.
Cholangiocarcinoma.
Of the biliary.
Cholangio.
Exactly. Dr. Abdullah, I'm sorry. so
But
that
the
next
what?
time you not answer my question again. I'm sorry. I'm sorry. So I
What?
just
What's the question again? Sorry.
I said cholangiocarcinoma is a tumor of the gallbladder.
No,
Gallbladder.
it's of the pancreas. Head of the
Which one is
pancreas.
Dr. Zulia saying?
No, Dr. Juliet, you said the right thing first of the biliary tract.
Yes. It is cancer of the biliary tract, not of the gallbladder. Do you guys
Dr.
get it?
Juliet, why do you change your answer?
Dr.
I was
Julia?
still in my head, I'm still calculating it.
Cholangio. See, guys, cholangio means bile duct. Cholangio, bile duct. That's what it means. Cholangio means bile duct. So when you have
What?
hello,
What's part of?
hello,
I said,
hello.
what's what?
Hello, we can hear you.
Okay,
So
okay.
I now went to go and say head of pancreas because I'm like the one that used to obstruct the tract is so it's actually the biliary tract, the cancer of the biliary
Yeah.
tract.
You know that the common bile duct and the pancreatic duct, they fuse together and the ampulla of Bartter,
Mm,
so that they can empty into
mm,
the second part of the duodenum. You get.
yeah,
So the
yeah.
pancreas is also encircling that second part of the duodenum. So when you have head of pancreas here, it can compress on that um ampulla of Bartter and the duodenum. So you can, it can compress on the ampulla
Let's
of
see
Bartter,
what we
so you
get.
can obstruct that duct. So
Yeah.
that is why cancer of the head of pancreas can cause obstructive jaundice, because it can easily compress on the pancreatic duct that is joining with the common bile duct and entering into the second part of the duodenum. Yeah. So the one that is compressing on the duct directly is the cholangiocarcinoma. That one is even within the duct itself, so there's no problem. So it will just cause the obstructive jaundice straight up. So two cancers that can cause obstructive jaundice: cholangiocarcinoma and C-head of pancreas. Yeah. So when you want to say gallbladder tumor, it has no name. That's the name. That's what you say it. That's what you call it as, gallbladder tumor. It doesn't have name like cholangio something carcinoma. No, gallbladder tumor, cholangiocarcinoma. They are two different things. Yeah. So your chlorotic sinus will cause cholangiocarcinoma. I want to try to bring you back. Do we remember anything that also associated with cholangiocarcinoma aside chronic sinuses? Anything associated with cholangiocarcinoma? We did it in GI. Cholangiocarcinoma, you are thinking of something again. Anybody? Is an autoimmune disease. Is an autoimmune disease.
One of those two.
One of those two. Yeah.
Primary sclerosing
BBC.
cholangitis.
Fantastic, Dr. Francois. Primary sclerosing cholangitis is associated with cholangiocarcinoma. That is why you want to do a prophylactic cholecystectomy for someone that has primary sclerosing cholangitis, because you are afraid this guy might eventually develop cholangiocarcinoma. Do you guys remember that is associated with the ANCA? Please don't forget to the
Yes.
antibody that you see in primary sclerosing cholangitis will be the ANCA, which is similar to what you see in someone that has.
Is it the other one, the Crohn's?
No, it's not Crohn's. It's not Crohn's.
No, one of the granulomatosis with polyangiitis, or
Okay. But that one will be microscopic cholangitis and obstruct. Because what we are looking at is what do we call it? C anchor, right? C anchor, MPO, like anti-myeloperoxidase and C anchor. That's what we are saying, right?
yeah.
So I think the one in ulcerative cholangitis is actually the P anchor and the PR3. I think it's PR3 and P anchor. So
So that's it's about mitochondria or something.
hello, you said what?
Like I know there's one that is about mitochondria
No,
something there.
mitochondria is the other one. That's the biliary cirrhosis. That's the biliary sclerosis. Primary
Okay.
biliary cirrhosis is anti-mitochondrial. This guy is P
Okay.
anchor. This one is P anchor.
Okay.
Ulcerative colitis and the primary sclerosing cholangitis. And another condition that's associated with P anchor is what? Wegener's, right? Wegners. Please, hope I'm not confusing us. Please, I want us to get those antibodies straight too. You know, we have
Ah,
C anchor, we have P anchor. Hope you guys remember.
Yeah.
yes. Yes, we know we have, but
All
the
right.
difference is what's in Garu.
Oh god.
But it's fine. Like I'll check it again. So I'll get it back.
Yeah. So, what am I trying to say now? Yeah. So that's all about the chronic sinuses. Biliary tract inflammation. You are going to have stasis of bile. There can be obstructive jaundice from there. There is bacterial superimposed infection that can cause cholangitis. Cholangitis can cause the pigmented stone from the bacteria causing conversion of the conjugated bile to the unconjugated bilirubin, which could lead to increased enterohepatic recirculation that cause precipitation of the stones at the end of the day. Yeah, so it can cause cholangiocarcinoma because the infection will also cause hyperplasia of the epithelium of the biliary tract, which can progress to develop cholangiocarcinoma. So you treat them with the praziquantel. So praziquantel is also used to treat the traumatose, praziquantel, just like the cystos too, that you give praziquantel, but with exception of echinococcus that you give albendazole, you also use praziquantel for these other ones. So let's talk about the ectoparasites. Ectoparasites, Sarcoptes cabi, number 1. That's scabies. Now,
Dr. Bawale, I just wanted to clarify. Dr. Francois said, was it primary biliary cholangitis she said, or primary
no,
sclerosing
she said
cholangitis?
sclerosing. She said sclerosing.
Okay. So it's the sclerosing that had the MPO anchor and all of that. Okay.
Yeah,
All right.
yeah,
Thank you.
she's correct. Yeah. So Sarcoptes cabi causes scabies. So they are mites that burrow into the stratum corneum of the epidermis, and they eventually form burrows within those skin, serpiginous burrows. That's what you see. So you can even see the burrow; they are visible to the eye, and they cause pruritus at night. So um, the reason why we believe that it's worsened at night is maybe because there's some period of quietness at night, so you can, when you are not moving, you can easily feel the pruritus. I don't know if you guys get that concept. Like when you are still, you can easily detect.
There's no distraction,
Exactly,
so
there's
you
no
concentrate
distraction.
on the little
Exactly,
things
that's the
that
word.
happen.
That's the word. There's no distraction, so you can feel that itchiness more at night when you are lying still. I think one of the clinchers to separate this from the lies, we saw a question like that. I think one of the clinchers is actually the location. The location is very important because both of them will actually cause the pruritus. But one thing about these scabies is that you typically find it within the digit, interdigital areas, like digit of the fingers or the toes. That's a common area. Although you can find it in the genitals, but commonly it will be in the fingers or the toes, interdigital areas of the toes. That's where you are going to see the burrows, you know. And it's very common in children. It's common in particular because the immunity of children is not very high, so it can easily affect children. It can affect areas where there is crowding, so like jails, like nursing home, military bases, you know, dormitories of schools, all those areas where there's crowding, like you can have transmission of the escape because it's majorly transmitted by contact to contact or by sharing of fomites like towels, handkerchief, bed sheets, and all those things. So what you want to use to treat it, just give permethrin cream or oral ivermectin. So what organism do we treat with ivermectin?
Resistant.
Strongyloides saccharalis.
Strongyloides
No,
acrobalis.
I've
That's
Strongyloides
not the first one.
saccharalis.
That's not the
elephant.
River blindness, I've
exactly river blindness. Uncle Saka. Oh. Uncle Saka should be the
Uncle
first.
Saka. Yeah, Uncle Saka was what I wanted to say. Uncle
Ah,
Uncle
Saka.
Saka should be the first thing that should be done.
Dr. Babawale, why? I thought, okay, I know what now.
No, no,
Strong.
I
listen.
can
Lloyd is
get.
strong. It
I'm
is
not saying you
strong.
are wrong. Oh.
Ivermectin, to use ivermectin.
Yeah, I'm not saying you are wrong, but this ivermectin is common, you know, commonly shared with treatment for onchocerciasis. I'm just, when we are talking about the nematodes, we talked about the first line for nematodes to be what?
Bendazoles.
Bendazoles. So
Bendazoles.
that's the first thing. That's the first thing for the nematode. All this ivermectin is just extra, and it's just few of them. It's only Stechurari that's using ivermectin. Parental palmate is for enterobius and hookworm. So all those ones are just extra. So it's very unlikely that they will test. If they are going to test treatment for the nematodes, it's going to be the bendazoles. But for onchocerciasis, the first line is ivermectin. Ivermectin. So that's why I'm trying to emphasize. It's not as if I'm saying you are wrong. No, you are not wrong.
Thank you.
Yeah. So scabies, permethrin, ivermectin. Then you have to eradicate all the sources too by spreading out the clothes, washing them, ironing them, so that you can kill off the mites. Then people that are also close contact, you want to treat them too by giving them the permethrin cream. So that's all about scabies, guys. Scabies is very straightforward. Once you see the location, you know what they are talking about. For the louse, the pediculus humanus and the fetrus pubis, those are the blood-sucking lice. They can cause pruritus too with Asher excoriation. Excoriation can be anywhere because excoriation is due to the scratching. And of course, if something is pruritic, you will scratch, and there's going to be skin exploration in response to the scratching. But it is a location that will help you. So you can have three types of lice. You can have the head lice, the body lice, and the pubic lice. So the ones we saw that day was the pubic lice, because that's the one that was found within the pubic and the perianal region. The head one, you find it in the scalp and the neck. The body one, you find out around the waist and the axilla. That's why you see the body lice. So what infection is being transmitted by the body lice? Anybody? We mentioned it too.
Oh, Rickety. Rocky Mountain spotted fever.
No, it's not
No,
Rocky
no, no,
Mountain.
no. That's triatomine bug.
No, that's not
Hey,
triatomine.
No,
motivation.
that's this
Which one
thing.
is triatomine? Now let's start from there. Which one is triatomine?
Triatomine bug is Trypanosoma cruzi.
Nice. That's kissing bug. Trypanosoma cruzi. So, which one is now Rocky Mountain spotted fever?
Rocky Mountain spotted fever. That's the rickety. Abi?
Yeah. So, the code we
So I
gave that
got
day,
my
Dr. Toby.
rickety. What I didn't get is the
The
Abby.
vector,
No, you see,
Okay.
no, the thing is, rickety is by a tick. It's not by the louse. It's by the tick. Tick.
Okay.
Tick. Rocky Mountain spotted fever. So rickety RR, Rocky Mountain spotted fever. And what is the triad of Rocky Mountain spotted fever? It's fine if you don't remember these things. There are a lot of information that we've discussed. So
Um, there are actually three. Something about the rash that is coming from the ankle to the body. Something
okay,
about fever. Maybe there's myalgia or arthralgia.
I
I
think
don't
that
know
one
which
is
one
even
it is.
fine. That one is fine. If that rash that is the most important thing, and you have said it, so it starts in the ankle or start in the wrist, and they can now move to the trunk. So we said that one is what? Centripetal. You are moving to the trunk.
Yes, centripetal, yeah.
From the ankle, it will spread to the sole. From the wrist, it will spread to the palm. Then they can also move inwards to the trunk. Unlike the other one, which is Rickettsia prowazekii, that is body lice, and
Yeah.
Rickettsia typhi, which is what? Which is the flea. So both of them, they can also cause rash, but their own rash is not from the extremity to the body, but from the body to the extremity. They start from the trunk and they go outward. They are centrifugal in their distribution, and they don't typically affect the palms and the sole like
Outflows.
Rickettsia.
My God. Okay. Mountain fever.
So we should not forget that. So once we are seeing the location, is it the head? Is it the neck? That's likely to be the head lice. Is it the part of the body like the axilla or the waist? That's likely to be body louse, which is the one that transmit our Rickettsia prowazekii, the epidemic typhus. P, epidemic.
Poor, yeah.
The
Poor
Rickettsia typhi,
epidemic.
the endemic typhus. That is it.
Endemic.
P,
Typhus.
P,
Typhus.
epidemic, and that is Laos. So itchiness around the pubic region, perianal region. So although there are so many things we are thinking of, it can be. So if you're having perianal itching, what else can it be? Aside our
Trichomonas vaginalis.
no
Could it be?
Enterobius.
perianal
Pain.
enterobius.
Okay.
Doctors,
Enterobius
it's perianal that I
vermicularius.
said. I didn't say vagina.
Okay.
Yeah. So
Yeah, I remember. Don't mind me. Thinking
I
of
know,
vagina.
there are a lot of things. See, this is how you can do it, guys. You just keep manning, just try to be remembering all those associations. That's how it can stay. Look at the way we emphasize all those three guys now. You cannot forget them. Those BAB, Babesia, and so you remember exotic three things: your Babesia,
Yeah.
your anaplasma,
Anaplasma
and
and
Borrelia.
Borrelia.
That's
Yeah.
the way you keep manning all those things together. So the perianal and the pubic itching, and you are thinking of an ectoparasite, is likely to be pubic lice. So you are going to see things in the option that will actually guide you to the answer. Yeah. So the body louse can also transmit Rickettsia prowazekii, which is the epidemic typhoid. Borrelia recurrentis, we talked about this too. Borrelia recurrentis relapsing fever.
It's a recurrent
Just
fever.
just coming
Absolutely.
and going. Then Bartholina quintana. I'm not sure they can ask anybody trench fever. It's not very common now. Fever, headache. They have muscle sore, like soreness in the muscle, particularly those of the legs, and they have hyperesthesia. You are touching it like this, they are feeling pain. So all those things. So, but it's not something that we need to learn. Just stick with the Rickettsia prowazekii. They can ask that one for the body louse. Don't forget. So you can use similar treatment that you've used to treat your scabies, to treat your pediculus humanus or your vitreous pubis, the blood sucking lice. We can use the parenteroid. Example of parenteroid is permethrin. So permethrin is a parenteroid. We can use it also to treat. That's why permethrin was also correct that day. Do you guys remember?
Yes, I remember.
Permethrin was also correct that day. You can use malathion, ivermectin, and you want to comb and neatly comb that hair, especially somebody that has the head lice. So they can be treated at home without interrupting the school attendance. Okay. That's that about the house. Then they talk about the bed bugs. So bed bugs have been added. The Cimex. So me, I don't stress myself learning the other names. Cimex is okay for me. Cimex species, bed bugs. So they are blood feeding insects. So they just bite and then they start sucking blood. They don't cause any serious illness like that. They don't cause any infection. It's just that they will keep sucking blood. And at the end of the day, they will bring about formation of a rash, pruritic erythematous purple with a central hemorrhagic puncture. You're just going to see like a dot in the middle, kind of, So once you see them describing something like this, it's likely to be bed bug. And that's the characteristic pattern. It can be clustered or linear. So it just follows the pattern of the bite. So it can be clustered or it can be linear. You see the body, and you guys have been bitten by a bed bug before. Anybody? Have you been bitten by a bed bug before?
I don't even know. Maybe I did not know it was bed bug or something.
But just see the rash in the morning. It's likely.
Yeah, it's possible.
So in OAU, I'm not proud to say it. There are a lot of bed bugs.
Is that why you are asking me to know whether we are on the same page?
Oh my god! It was when I got to school. That was the first time I saw it. I just hear it. I've
I
not
don't
seen
think
it
I've
before.
ever seen it before. Even though mango, but I don't think I've ever seen it before. I don't
I've
think I've
seen
ever.
it though. I've seen it. Just be crawling along the bed like this.
Yeah.
Where there is overcrowded, that's where you see them. Poor hygiene, overcrowded areas, that's where you see the bed bugs. Especially where there is poor hygiene, that's where they are. So they come out at night. You see them moving across the borders of the bed.
So OAU has poor hygiene.
Welcome.
No, let us pause this. So
Bring it.
somebody
Bisola, I wish I could.
so it's done now. So yeah. So people can, move it from one area to another area, especially travelers, so they can take it to different area like hotels, and if they don't wash the beddings of those hotels regularly, they can spread it to other customers and they can start spreading it all around like that. So they just cause bites, and the bites it resolves within 1 week. So you need to eradicate the parasite. That's the only way you can treat it. So some people fumigate. Some people also use permethrin to treat people that are infested with the stuff. Yeah. So let's go and look at those hints. So there's a table that talks about the hints, and I know we've talked about this. So biliary tract disease, cholangiocarcinoma, that is Cronarchy sinensis. Brain
Not
cyst,
cheese.
yeah, so don't forget.
Liver fluke.
Bile tract, biliary tract, Cronarchy sinensis. Brain cyst, multiple brain cysts.
Neurocystic psychosis.
Exactly. Neurocystic psychosis. Seizures. Neurocystic psychosis from Taenia solium. This is not Taenia saginata. We are not talking about saginata here. This is Taenia solium. So somebody having periventricular calcification, chororetinitis, and microencephaly, what's your diagnosis?
This thing now.
That's toxoplasma. Oh, that's CMV.
CMV.
I'm happy.
That's
I'm happy
CMV.
you guys.
Say it again.
You
Say
guys
it
are very,
again.
very much conscious, and I'm very happy.
CCC, Abi. Okay. CCC. Okay.
You guys know that I will not ask you Togzu. It will be true, because I want to know if you actually paid attention to the second one we mentioned. So CMV.
Yeah, I remember you said it's. You said periventricular. The other one is intraventricular. It's intraventricular. I got it.
Intracranial.
Intracranial.
Yes.
Intracranial.
So intracranial calcification is Togzo. Periventricular calcification is CMV. CMV, we have microcephaly. The other one, Togzo, is hydrocephalus.
Hydrocephalus.
Then the chororetinitis is common to both of them. Chororetinitis. Yeah. So multiple brain enhancing lesion. Someone that is having HIV/AIDS, it's likely to be
Toxoplasma.
It's likely to be Togzo. It's likely to be Togzo. Yeah. Hematuria, squamous cell bladder cancer.
Hematobium.
Thank
Just
you.
a hematobium.
Liver cyst, hydatid cyst, eggshell calcification following exposure to dogs.
Echinococcus.
And anaphylaxis.
And anaphylaxis. God bless you, Dr. Olatobi. So what do you give to treat?
Albendazole.
When it are complicated, what do you do?
You do surgery.
You train surgery.
So what's the treatment for Cronarchy sinensis?
Is it not ivermectin?
Praziquantel. Dr. Olatobi, ivermectin is the... See, Dr. Olatobi, forget ivermectin for
others.
Forget it.
So it's just the Onchocerca and Strongyloides, those two.
Exactly.
Okay.
Taenia solium, what's the treatment? Neurocystic psychosis, how do you treat?
You remove the cyst now. No, you do what?
Dr. Olatobi wants to go and remove many cysts.
Sorry.
Inside the brain.
Sorry.
All right,
Psychosis.
Wow. Are you not going to give the bendazole still?
So you give the praziquantel first. The praziquantel
to kill. Okay.
To kill it in the blood. Then the one that will now go and take care of it in the brain is what? The albendazole.
Okay.
Don't forget. Sorry, Dr. Olatobi, don't worry.
So praziquantel for first eradicate for to kill them, and then after you now give bendazole to go and eradicate
the one in the brain. Because of course, for it to get to the brain, there are some already in the body, right? The other part of the body.
Of course, yeah.
So if it's normal one, maybe in the intestine, you just give your praziquantel. That's okay. Whenever you are thinking of the cystodes, and the trematodes. The trematodes are the schizostoma and the clonoches. The cystos are the tapeworm. Always remember praziquantel first. Unless there's
Okay.
specialized situation. What are the
Tapeworm
specialized
in the
situations?
post.
Echinococcus is a specialized situation. Echinococcus is the only one that is causing the cyst. That one is
No,
aberrant.
I've done that too.
Iron deficiency anemia.
Hookworm.
Hookworm.
Phlobotum latum.
Nice one, doctor. What else about the hookworm? What
No.
else?
Iron
Sorry,
deficiency and
hookworm.
Dr.
Iron
Tuli had
deficiency is
ah
hookworm. Emma
ah
Bino Ejao.
ah
Emma
So what else about the hookworm?
hookworm.
Um,
This
the
skin,
hook
it enters from your barefoot
It enters from
and
the bare
the
food.
be walking
and the
around
rash
cutaneous
walking around.
lava
It causes
migrants.
serpiginous rash.
They cause the cutaneous dermal migraine with a serpiginous rash. You get it. Myalgia, periorbital edema in somebody.
You
Myalgia.
said it too. You said it.
Periorbital edema. That one is
edema.
two. It can enter via two places. Oh, myalgia.
Trichinosis.
Yes. Trichinosis. Through what?
Eating.
Eh?
Eating.
Eating of what?
Eating is require meat, undercooked meat.
Exactly. Pork. Yeah.
That's true. After I said it, my brain shall open up.
Do you get? Like when we say we don't know more, it is well.
So nocturnal perianal.
So myalgia, periorbital edema, myalgia, myositis leading to myalgia, periorbital edema, trichinosis, trichinella, undercooked pork meat.
Undercooked pork, yeah.
And it enters through your
GIT, blood vessel.
Nice one, Dr. Toby. Nocturnal perianal pruritus.
Necator. No.
Nocturnal. Escapist now.
Worm.
No, perianal.
Wait, perianal. I didn't hear perianal. I didn't hear perianal. Pinworm. That's Enterobius vermicularis.
Vermicularis.
Okay.
I didn't hear the perianal part. Sorry.
All right. So if it's not nocturnal now, and it is just perianal pruritus, aside pinworm, what else did we say?
Strongyloides sacroralis.
No, which one is Strongyloides sacroralis?
You said pruritus.
I said perianal. Perianal. Okay, it's like communication is our. Let me be pronouncing it well. Let me be saying it well. Perianal pruritus. So that is not nocturnal. So what else?
So Baba Wale, what are you doing? Bisola, this your network is for sharing go.
Yeah, so I said one of those louse, those lies, those guys. Which one is the plural now? Is it lies or louse? Louse is the
lies is plural. Louse is singular.
Okay.
That's what I think.
One of the lies.
You are teaching our teacher. You are teaching our teacher.
Who am I?
Everybody.
Continue, Dr. Babawadi.
Everybody. Who am I? Yes.
So continue. One of the lies. Sorry.
Is it like the typhy louse that you just mentioned?
So it will be the head louse. It will be phthisis
pubic louse.
Pubic louse.
Dr. Oluwatobi said there's louse for perianal rash again.
That's funny actually.
What are you asking? Please, what are you asking?
Perianal pruritus.
That's the pedunculus something, right? The pedunculus.
Yeah. So.
Okay.
So we have those lies can be three: the body, the perianal or the pubic, and the head. Head, body, pubic. Head, body, pubic or perianal. Pubic or perianal. Head.
And that's why I said phthisis pubis now.
We did not hear. Everybody did not hear.
Dr. Baba.
No, we did not hear. It's head that we heard. We said head.
Thank you. It's head that we heard.
I said head louse. I now said phthisis pubis. Oh God. Takunla. Oh,
Kí ló jẹ́ bẹ́ẹ̀? Ìtákùn nìkan kọ́.
You get
anything, you shall get it.
get it. So
Wahala.
portal hypertension. Portal hypertension.
Porter, schistosoma,
Schistosoma mansoni,
Mansoni,
schistosoma
Japonicum.
japonicum.
Japonicum. So this is not the time to remember hematobium. No. B12 deficiency. B12 deficiency.
That's the
B12,
diphyllobotum.
diphyllobotum latum, the
That's
largest
diphyllobotum
tapeworm in the world.
So how do they get diphyllobotum latum?
Fresh water.
Fish water.
Fish.
Fresh water.
Yeah.
Fish fresh water.
Yeah. Fish fresh water. Fresh water fish.
Fresh water fish.
Anyone.
I miss Dr. Francis' voice.
I'm
Yeah.
telling you.
Yeah.
It's probably at work.
Oh,
Yeah. You are right. I think I remember. Oh, yeah.
Oh.
Yeah.
What
are we asking? What are we asking? Oh,
That's
oh.
No,
Yeah.
I think I missed it. Oh, I remember now. Oh, thank you so much.
You're very good at making someone do that, Daniela.
Oh my God. Ah.
Dr. Lushola said from muted.
Dr. Oluwajola will have you like, is it Dr. Oluwajola? No, this is Dr. Oluwajola typical way. Is it? Is it tapeworm? That
So,
Dr.
who
Oluwajola
is it you're
answers
talking
with
about?
question.
Dr. Babawale?
That got me.
He answers with question. Is it tapeworm?
No, I'm trying to understand, but Amber said,
Amos said, I read it. No, Dr. Babawale, you know what? I read it somewhere that they said.
is that possible? Is that what he's talking about? Is that Amber?
It's almost like someone.
Oh my God. That man and Ambos, now God go help him.
Dr. Babale, you said you saw which question. What did
Yeah.
that question
What's
say
that question
exactly?
again? What's that question?
Where did it, no. I was just reading it somewhere and it said, okay.
In fact,
God.
Doctor,
Now they
it's
do
another-
well.
It's another.
It's like,
It should be studied.
but I shall miss Dr. Baba, Dr. Francis was voice. That's my own. Virology!
We are fine that.
We don't enter the virus. Yeah. So let's
Please,
just
I
talk
hope we are
about
muted though. All these things we are saying is not here. It's not playing no.
guys, make I don't lie you.
Ah,
But it's just that part that we're just talking about. We're just making how people talk. It's fine. Let's continue.
Can you delete it? Can you delete it?
No. It's okay now. It's fine.
No, now stop.
Let us leave that one.
It's fine, Jare. It's just fun.
Everybody will just be
Should
laughing.
be between us. It's shy between us.
Oh, God.
Oh yeah. Let's continue.
Yeah, let's continue. Virus.
So the virus, we are now talking about virology now. So we have to talk about the viral structure. So a typical virus contains two basic things: the nucleic acid, which is the genome, and the surrounding capsid. So surrounding capsid and the genome, which is the nucleic acid, which can be RNA or can be DNA. So for a virus that is naked, it doesn't have any envelope covering the capsid or the nucleic acid. And most of them are icosahedral with respect to the shape of the capsid. So like 7 side, 1, 2, 3, 4, 5, 6, 7, yeah, icosahedral capsid. That is that. So it is naked because it doesn't have envelope. It just have the capsid. So that capsid is not enough to call it covered. It has to have envelope. So once it doesn't have envelope, it is naked. And most of the naked virus, they have the icosahedral capsid. There are two types of capsid that you can have. Is either is helical or icosahedral. That one is not high. Nobody will ask us, but we are just talking about it just to know it. Yeah. So some are not naked. They actually have an envelope covering the capsid. Now, what are those things that are found on the envelope? You can find the lipid as well as the surface protein. Now, most of them get the surface protein, they synthesize the surface protein themselves, but they derive the lipid from the host. So that is it. They synthesize the surface protein through their own biosynthetic machinery, but they can infect the host and form the lipid bilayer and get the lipid bilayer to form to complete the envelope from the host. Yeah. So any virus that contains the envelope, we say it's an enveloped virus and it is not naked. So we can have an envelope virus that has either the icosahedral capsid or the helical capsid. You guys you remember that I said that once it doesn't have the envelope, it is
It is icosahedral.
icosahedral, exactly. You don't have any virus that is naked that has an helical capsid. No, they don't exist. Now, what do you mean helical capsid? It has the helical shape because the capsid is intertwined with the nucleic acid. You guys are seeing that this capsid is like covering, it's for the icosahedral one, it's like the capsid is like covering the nucleic acid, it's like shielding it. You guys can see the appearance. But for the helical, they are intertwined together, they twist around each other. That's one thing about them. Then they now have the envelope, just like we can see. Then we have the last one, which is a bacteriophage. So bacteriophage is just like the virus too, that helps to transmit genetic information from one bacterial cell to another. So they typically contain the capsid and the nucleic acid and some other protein structure that assist with their action, like spikes. So this is the way they look like, the bacteriophage. They look like ants. So once you see this, you know that this is a bacteriophage. Yeah. Now let's talk about viral genetics. Viral genetics. So the first thing is recombination. Recombination is not a new thing. We have talked about it even when we're talking about meiosis in humans. Meiosis when we're talking about biochemistry in eukaryotic cells. So the same thing happens here. Recombination is just exchange of genetic material between two chromosomes of viral cells. So if you have two viruses infecting the same cells, they can exchange genetic material by crossing over. So that crossing over typically occurs in areas of similar sequence homology. That is, areas where the sequence of the DNA or the RNA is similar. That's where they have the exchange. You guys remember that when we're talking about crossing over or homologous recombination in meiosis, we said it happens between two homologous chromosomes. It doesn't happen between chromosome 1 and chromosome 10. It doesn't happen between chromosome 10 and chromosome 12, but the two homologous chromosomes of chromosome 1. So we are going to have the paternal copy and the maternal copy. So, of course, they are going to have some similarities. So that switching, that exchange happens within strands of chromosomes that share some similar base sequence. So don't forget that. So it is not very common in segmented genome because that segmented genome one is very similar to recombination. So just know that recombination is exchange of genetic material between two cells that together they infect a cell and they exchange their genetic material. And the exchange happens between sequence of genome that shares similar base sequence. That is it. The next one is reassortment. Now, reassortment is a phenomenon that occurs in viruses that have segmented genomes. Very, very important stuff to remember. Viruses that have segmented genomes. So the Automaxoviridae, the Paramaxoviridae, all those guys are having segmented genomes. So they are very, very notorious for undergoing this reassortment. An example of a virus with segmented genome is the influenza virus. So they exchange their genetic material. One thing that is peculiar to this reassortment is that you have, let's say we have two different strain of a virus infecting a cell. Now, when I say two different strain, we can have human strain, we can have avian strain, we can have bovine strain. Avian, the one that affects birds, bovine, the one that affects sheep, human, the one that affects human. Now, when they infect a cell, a host, they can share their genetic information. So at the end of the day, you are going to have a cell that has genetic material of both of those strains. That is important for a concept called antigenic shift, because that particular virus is going to be expressing antigenic protein that is peculiar to both of the strain. Now, human influenza virus that is having a segmented genome, infect a cell. Another virus that typically infect pig, infect another human cell. Both of them infect human cell. Now they now share their genetic information. They now produce a progeny that contains the gene of both the human influenza and the pig influenza. Now that progeny is going to express protein that is, common to the human influenza and the pig influenza. Now that will cause antigenic shift because it will be very difficult for the immune cells to respond to that particular strain because they are being used to producing antibody against the one that already express protein for the human influenza and express antibody against the one that um, infect the pig influenza. Now, when you are now having an hybrid, the one that contains protein from both the human and the pig, it will take time for the immune cell to develop antibodies to respond to that. So it will keep infecting so many, people, and it will lead to pandemic at the end of the day. So once you are seeing something that looks like recombination, but is happening in viruses with segmented genome, you know that is reassortment. You are reassorting the genome. Do you guys get that?
Not really.
Okay. Now, this is it. For the recombination, it's like you are like exchanging genetic material between a strand. Like this strand is going to integrate into another strand. That is what is happening in recombination. Do you guys remember the crossover that we talked about? So if you guys remember what we talked about in crossover, we are going to have, like, let me say chromosome A and chromosome P. Now you are going to form chromosome B that will contain some portion of chromosome A, and you have chromosome A that will contain some portion of chromosome B. That is recombination. Do you guys get that?
Yeah,
Now,
we get the recombination, the reassortment now.
so
Yeah, we get the
reassortment.
recombination. Yeah.
So that is recombination. In reassortment, it only occurs in segmented genome. So you are just picking a portion of the segment from one virus, and you are picking another portion of the segment from another virus. You are mixing it together to form a progeny that contains both information. Can you guys see this picture? So
Okay.
we are picking a segment of virus A. We are picking another segment of virus B. We are now forming a progeny that contains both of them. It's only segmented genomes, virus with segmented genomes that can do this. If this guy is not segmented, what it can do is just recombination. They will just intercalate, because just imagine this one has only one chromosome. If it gives out that one chromosome, how can it give out its own chromosome? It's going to die now. What will it use? Do you guys get that? Because
Yep.
it's not segmented. So in the reassortment, you are just transferring a particular part of your own genetic information, mixing it with genetic information from another virus to produce a progeny that contains both. Do you guys get that? So now this progeny is going to elaborate proteins, a mix of protein that is peculiar both to the first virus and the second virus. Do you guys get that?
Yep.
Now, that is that. We are now saying it can cause antigenic shift leading to a pandemic, because now let us take the situation of the 2009 novel H1N1 influenza A. Now, what we are usually used to is the human form of that influenza. We have the human form, the one that infects humans. We have developed a vaccine against it because we know the protein that one elaborates. We know. You guys know that we develop antibodies against the antigen, and the antigen is a protein, right? You guys know that. Now, we know the one that is derived from swine, from pigs. We have antibodies against it. We know the one that is derived from birds, the avian. We have antibodies against it. So that means that if there is an influenza infection outbreak now, all of the individuals that are vaccinated against it, that have the antibodies, they cannot develop that infection. Is that correct? Because you have antibodies to tackle it, right? Now, if two different strains of a virus, that is the human and the swine one, infect a cell together simultaneously, they exchange the genetic material and they form progeny that have a mix of their protein. You know that the surface protein that one will be expressing will be different from the surface protein that the individual guys are expressing. Do you get it? Because the protein that will be expressing will be a mix, is a product of the mix of the genome.
Of the
So it will be
two.
quite different from what individual ones will be expressing, that is the human and the swine. So the antibody against the human one cannot work against the progeny. Antibodies against the swine cannot work against the progeny. Do you get it? Do you guys get it?
Okay.
So that is
Yep.
what we call antigenic shift. That is the antigenic shift. Because it's going to produce a protein that is an hybrid of the individual ones.
Okay.
So because of that antigenic shift, you cannot mount immune response against it. You cannot, the vaccination that's already established cannot take care of that new hybrid strain. So it's going to keep spreading because it will take time for us to now figure out that strain and now develop an antibody that can respond to it. But before we do that, it will have spread. It can even spread as fast as across countries and cause pandemic. Do we get that? Because of this reassortment of this genomic segment into a new cell that contains the hybrid of the genome. Do you guys understand that?
Yes.
So that is peculiar to
So,
reassortment. Reassortment is only occurring in segmented genomes. Any virus that has segmented genome, that is where reassortment can happen. Don't forget that. And it can lead to antigenic shift. It is different from antigenic drift. Antigenic drift too is like a change in surface protein that can cause the epidemic or pandemic. But that one is due to the fact that as these viruses are not actually exchanging material. It's just that as individual viruses are replicating, they tend to accumulate mutation. You guys know that the repair mechanism or the repair mechanism of a prokaryote is not as efficient as that of an eukaryote. I'm sure you guys will believe that, right? So over the time, as it's replicating, the mutation will be accumulating. By the time the mutation gets to a point, it's now going to alter the gene sequence and they'll start producing a protein that is different from the protein that they usually express. So it's like we have changed the surface antigen too like that. But in this situation, it's actually due to continuous proliferation with acquisition of so many mutations that leads to changing of the DNA sequence, which eventually changes the surface antigen, and that's antigenic drift. Do you understand that?
Yeah.
So that means that if you are thinking of
Okay.
antigenic shift, you must always remember that okay, that one requires infection between two viruses. Infection between two viruses so that they can exchange the material and they can produce an hybrid. But for antigenic drift, it's only one virus. But that virus is replicating, is accumulating mutation, it will alter the DNA sequence, they'll start producing new protein that is different from the protein that we are used to. The protein that is producing the antigen that we are developing antibodies against. But now it has acquired so much mutation, it has changed the DNA sequence that they are now producing new protein that's different from the usual one. That is antigenic drift. So antigenic drift is not sudden like antigenic shift. Antigenic drift occurs over a period of time. But antigenic shift can occur suddenly. So once you have that infection, they produce progeny, bam, it starts happening. But you need time. It's your antigenic drift occurs over a long period of time. So that is it. I think it's past 6. Let me just allow us to go and digest what we have learned. So we will continue from here tomorrow. So I'm sure you guys understand what we've talked about with respect to. So I think Dr. Oluwatobi have seen a question on antigenic shift and drift. Dr. Oluwatobi, because we are trying to mention it one time like that. Dr. Toby.
Yes, I have. And there is even one I wanted to ask. There is something they were describing that all these changes, which of them can they pass on to their progeny?
So which one now? From what we have said
So
now.
this thing can transfer now. The recombination can transfer.
You see, that recombination usually it can transfer, yes, but it's usually between yeah. So let me just agree. Let me just agree that it can transfer.
Talk now, talk. Say it,
No,
say
no,
it,
no.
say it.
It can transfer. It can transfer too. I just don't want to localize it to the crossing over that happens in eukaryotic cells.
Okay.
But I believe that it can also occur in the same virus, because what you are doing is just like exchanging genetic information between two different chromosomes. You know, like if you look at crossing over now, crossing over is happening in a cell. It's not occurring in when the two cells are mating. No, it's actually occurring in that cell. It's just that each of those cells contain 46 homologous 23 homologous chromosomes, right? So each of those homologous chromosomes, they can exchange. Like chromosome 1 now, you have the paternal copy, you have the maternal copy. You can exchange your genetic material between them. It's just chromosome stuff that is just coming together and they are exchanging. Do you understand? I'm sure there's going to be more detail to that question, Dr. Toby. It will be beyond
Of course, I can't find it now. I have to like search. Well, once I'll bring set questions on it. I'll put it on the page.
okay, but most likely that question will be talking about reassortment.
It was actually reassortment and phenotypic, but the answer in that question was phenotypic mixing.
Oh, then there's something else. There's something else they are doing.
Yeah, let me just even start searching.
So maybe they are talking about the effectivity that okay, it's kind of
increases. Yes, it increases how the pathogenicity of that virus.
Yeah. So that's phenotypic mixing. That's phenotypic. They are not exchanging genetic material. In phenotypic mixing, you are not exchanging genetic material. That is it. So you are just like how do I put it? Like make the other virus acquire protein that can allow it affect the same cell that okay, like you are making virus B infect cell that virus A can infect. So when you transfer the protein codes from virus A to virus B, so like here now we are actually transferring the protein code from virus B to virus A so that you can allow virus A infect cell that virus B can infect, increasing its tropism. See, they don't exchange genetic material in phenotypic mixing. They don't exchange genetic material. So you produce a progeny.
So that one,
So you
but that
produce
one shouldn't be able to reach a progeny then.
No. You know that these viruses, they are dividing. They can divide. You get now. If they just exchange their protein codes, virus B transfers its protein code to virus A. You get. So the only importance of that protein code is just to allow virus A infect cells that B can infect. That's the importance of the code too. So when virus A now infect that cell, it will now start dividing and it will start produce, because it is the DNA that will determine the protein code. You get. So it's going to produce a progeny that is still having its own genome and its own protein code. Let me explain what I'm saying again. You have virus A, you have virus B. Now, phenotypic mixing is that now virus A has limitation in the kind of cell that it can infect. Virus B can infect more cells. Now, you want to make virus A infect cells that virus B can infect. How do you do it? Transfer the protein code from virus B to virus A.
Oh, I get what you're saying now. Okay.
So when they transfer it, virus A is having the protein code of virus B, right? So it will be able to infect some
Mm,
cells. When it infects
mhm,
those cells, you know that the genome of virus A has not changed. It's only the protein code that changed. You get the capsid.
mhm.
Now, when that virus A has infected that cell, it will replicate. When it replicates, do you think it's going to produce offspring that's still going to retain the protein code of virus B?
No,
No, because it is the genome that will dictate what will
it is
form.
yes. What is in the DNA is what determines what the offspring can have.
You get the idea.
Oh,
So,
now you will see the question. I'm blotting out the answers. So
okay.
it picked like all the stuff we just talked about. Sure.
Yeah, let us see. So let's just end the class and look at the question.